Welcome, everybody. It's really good to be here at the 41st annual meeting. My topic is to talk about the California OSHA Aerosol Transmissible Disease Standard and the decade of experience that we've had with that standard, and think about how that might be useful in informing the state and federal standards that are being developed because of the pandemic. I was fortunate enough to become involved in the development of this standard back in 2004 when it was first started to be discussed, and I've been working with local unions, with SEIU and other unions and employers around this issue for the last 17 years, and a lot of work during this pandemic. I wanted to the standard was adopted in 2009, and it was designed to protect employees in the covered work areas, healthcare and beyond, who are at increased risk of contracting droplet and airborne spread infections because of their work. And it's a California OSHA enforceable standard that sets minimum requirements for these protections, and it is one that covers both droplet and/or airborne spread diseases and precautions, and it's based on CDC definitions and guidance that were out in 2006 with some additional elements for occupational health. This standard was developed by the Cal OSHA Unique Standards Board, which has been very active in developing new standards that don't exist anywhere else. It's also and I wanted to give a shout out to Cal OSHA staff, Deborah Gold, who was really key to having this standard both become developed and actually be adopted and used afterwards. She had retired a few years ago and then went back in the spring to work for Cal OSHA because of the pandemic. Okay. This standard is the only enforceable standard for occupational health that covers the coronavirus and other airborne droplet spread diseases in the U.S. up until recently. And so I think it's a useful thing to look at. It's a rare standard in that it actually started with a request from California healthcare employers, and I'll describe that rationale for that in a few minutes. It was also a rare standard in that at the Standards Board meeting, which unanimously voted to adopt the standard in May of 2009, it was endorsed by everyone in the room, including the employers. And Deborah Gold and her staff got a standing ovation for their work on developing a standard, which will probably never happen again. Right? It is we've always thought it could become the model for other state and federal OSHA standards, and federal OSHA has been looking at this standard since the end of H1N1 in 2010, and it has been looked at as a model. It's in the past, in California, they developed a bloodborne pathogen standard early on, and also a safer sharps protections in the 1980s, 1990s, and then those both ended up becoming federal standards and protecting way more workers. And we always thought this could be the case with this. We didn't expect a pandemic to happen. What's interesting about the final vote of the Standards Board, and looking at the history of it, the vote was at the beginning of the H1N1 pandemic, at a point when nobody knew if this was going to be what we're facing today, and it didn't turn out to be. So there was a lot of concern about the need for this standard and how it might be implemented, because we were wondering if we were going to be facing this sort of huge pandemic. Let's go back 30 years just quickly to sort of look at this standard, where it came from. So in 1991, OSHA issued, after many years of work, its bloodborne pathogen standard. We're going to hear much more about that from our next speaker. This has been an incredibly successful OSHA standard. And so shortly after this, there was a rise in tuberculosis cases in the US. And so OSHA then initiated looking at rulemaking around tuberculosis in 1994, and they issued a proposed rule in 1997. What they also did, though, and because of that proposed rule in 1998, OSHA updated their respiratory protection standard, and they gave the healthcare industry an exception to the new standard for a number of issues, including fit testing, because they expected to come out with a full-blown tuberculosis standard where those issues would be covered. So if we move into the 2000s, in 2003, OSHA made a decision to withdraw and end the rulemaking on tuberculosis. And what that meant was that healthcare employers who had had this exception for a number of years were now required to follow the OSHA respirator standard, including fit testing. And that's really what drove employers to come to Cal OSHA and say, can we get an exception and some relief from fit testing requirements? Cal OSHA's response was, maybe, but that would be as part of a comprehensive infectious disease standard for airborne and droplet spread diseases. And the industry said, okay. And then every other stakeholders jumped on. So this standard was developed over the period of 2004 to 2009, and then was finally passed in May of 2009. And federal OSHA has been looking at this issue almost ever since. Okay, so there is a brief history that I've written up, a couple page history of the adoption of this standard, because I think it's got a really unique, interesting history. And so that's available, I believe that was in materials that I sent along and should be available, or if people reach me by email, I'd be happy to pass this on. Okay. So let's look at the standard. Okay, so here on the left is a guidebook that Cal OSHA actually came out with, the first version actually in January of 2020, right before the pandemic hit, and it's been updated since. This is actually a very best document to understand the standard, the elements of the standard, with lots of good advice on how to comply with the standard, but even go beyond compliance. And so I'd urge everyone who's interested to grab a copy of this off the internet and to look at this, because Cal OSHA did a really wonderful job on this. Here on the right part of the slide, this is the outline of the ATD standard. And if you're familiar with the bloodborne pathogen standard or other OSHA standards, this has a familiar look to it because it followed a similar outline. And the key to this standard, though, is element D, the Aerosol Transmissible Disease Exposure Control Plan. I'll talk more about that, but that's really the heart of this standard and is what needs to be the heart of any infectious disease standard that's going to be effective. So this standard took these lists that are for the diseases that were listed on the 2006 CDC site for airborne infectious diseases. And so you see things here of measles, and you see shingles, and we see tuberculosis, which was kind of the original push. And you see SARS is also listed from 2002, 2003. It does include this element that was added of novel or unknown pathogens. And this was because the expectation that things would show up like SARS had that weren't on the list, and that Cal OSHA wanted to have a way to be able to require employers to deal with these novel pathogens. And this was used for H1N1. It was also used for Ebola, and it's been used in the current coronavirus. And the ATD standard, with the support of the California Department of Health, has considered the coronavirus an airborne spread and droplet spread disease since the very beginning of this. And so while there's been this debate nationwide, legally in California, this was settled a long time ago. Okay. This is a list of the droplet spread diseases from the same CDC list in 2006. So that's in the standard. The scope of the standard is limited. It does not apply to all workers, which many of the standards that are now being looked at in the federal OSHA emergency temporary standard that we're anticipating soon will cover all work sites because of what the coronavirus has done. But in the scope of this standard was primarily healthcare, but not entirely. And so this is the range of healthcare work sites and operations that were covered. So certainly all sorts of sort of hospitals, skilled nursing facilities and nursing homes and long-term care, but it also included small medical offices and other outpatient medical facilities, and facilities where high hazard procedures, aerosol generating procedures are performed, which put workers at greater risk. Home healthcare is included, medical outreach services such as testing and contact tracing, And then the emergency medical services were also covered. And we've seen in this pandemic, many of these work sites have been the sites of large outbreaks or ongoing concern. But there were other sites also covered. And so facilities that might receive persons arriving from the scene of an uncontrolled release of biological agents under the hazardous waste standards. Police services for police services around persons who might be known or suspected to have one of these diseases, public health services. And then partly because of the experience with TB, there are these lists of correctional facilities, homeless shelters, and drug treatment programs as possible spreading centers for these diseases. And so they were also included under the standard. And then finally, facilities that might do work like medical examiners' offices, coroner offices, mortuaries. There's a section that covers laboratories that are handling these pathogens. And then this broad category H of any facility service operation that's determined by the department, by the chief of OSHA, would be covered. And they wanted to make a point that maintenance, renovation, service, and repair operations by both staff and and contractors at any of these facilities are also covered. And we've seen that in a number of cases in California where this was a really important aspect of the standard. Okay. Now, I mentioned that the exposure control plan is really the key, and these are some key parts of this exposure control plan that are spelled out in the standard. This is not, if you've looked at the bloodborne pathogen standard again, this is sort of not, this may look familiar. So there needs to be the name of a person responsible for administering the plan, and that person needs to be knowledgeable in infection control principles and practices. And this is so that workers, unions, anybody who has a question at that facility knows who to go talk to about the plan. But it also includes that there has to be a list of all job classifications where employees might have occupational exposure. And so this is part of the hazard assessment piece. There has to be a list of all the high hazard procedures, aerosol generating procedures, and the jobs related to those procedures, so we know what workers might be exposed. Okay? And there needs to be a list of all all assignments and tasks where workers would need to wear personal protective gear or respirators, and what that needs to be, so that workers aren't guessing whether they need a respirator, whether they need face shields, whatever. This is something the employer was supposed to put out as part of their hazard assessment and the development of this exposure control plan. And then finally, the method of implementation of specific controls. And the employer has a lot of leeway in making this determination, but they need to use the hierarchy of controls. And the plan needs to be site specific, it needs to be effective, and it needs to be in writing. And I think the most important piece of this is that it has to be site specific. As we've seen plans that have been provided that essentially look like a copied CDC guidance from their website, and you couldn't tell what facility it was for, then that doesn't meet the standard. So the plan needs to be, the work site, as I tell workers, you should recognize your work site when you read through a good exposure control plan, and you should be able to understand the details of what they're talking about. Okay. A few other parts of the standard that I think are both useful and interesting is this one under the medical services section H for precautionary removal. So this has been a huge issue, I think, around the country. But in California, if there was a precautionary removal after an exposure incident that the employer investigated, then there is a requirement that the employer must maintain the employee's earnings, seniority, benefits, and all other employees' rights as if they were continued working. And this is language that we borrowed from the OSHA lead standard that's been around for decades. But we saw this was an important way to protect both workers and also to ensure employers to investigate these incidents as well, and also then to fix whatever the problems were that led to the exposure incident. And we saw in the first case at UC Davis in California early in the pandemic that there were over 100 healthcare workers who went off on precautionary removal at one of the first cases that happened under this pandemic. So this has been a big problem in terms of if this is done properly, not only are you losing lots of staff, and Robin mentioned this with meatpacking plants, but in California, you were obligated to pay for all the benefits and keep people on payroll. Okay. There's also an extensive record keeping section of this standard that requires lots of different information. Certainly the annual review of the ATD standard plan, the records of exposure incidents that have occurred, and lots of others. And this is really important so that, number one, that it's possible for Cal OSHA or unions or others to go back and look and see what happened. And we're hoping that at the end of this pandemic that there'll be a deep dive into many employers' records about how they handled this pandemic so we can learn from that. Okay. This was tied into the longstanding OSHA access to medical and exposure record regulation. It's been around since 1980, so this wasn't something that was new to employers. Just the types of information was specified so that they knew what they had to keep. And when this was developed and discussed among all the stakeholders, this is at a point in the early 2000s when there was a lot of pandemic flu planning that was happening at state and federal level and involving private sector folks also. And I was at lots of those meetings. And so we, in the development of the standard, we discussed and included language that required employers to prepare for surge events or for what we're facing now in terms of mass, sort of mass spread of disease. And I think this has been probably one of the weakest parts of the standard that probably needs to go back and get revisited. And the state of California is already adding specific laws and regulations that are going to strengthen this issue, not just for ATD standard covered employers, but for, I think, employers across the state. Okay. Now, this standard's been around for more than 10 years. And so this is one where employers that were covered have known what the standard is. They should have been in compliance for a long time. They've used this standard through H1N1, through Ebola, through whooping cough outbreaks, through measles outbreaks in California. So this is not something that was brand new when the pandemic hit. But here's the experience, I think, that kind of summarized over the first 10 years. So the standard was helpful in that it created clear enforceable requirements that both workers and employers would know what should be done. Okay? It also gave Cal OSHA a seat at the table so that when there were discussions about infectious disease, Cal OSHA was not forgotten. It requires worker and union participation, mandates preparedness, and it essentially makes the California Department of Public Health requirements and the 2006 CDC requirements enforceable. So that's sort of the good news and we saw good use of this where we found improvements in negative pressure isolation rooms. We found better response to whooping cough and measles outbreaks and better access to vaccinations and things. And then came the 2020 pandemic. And I have to say, this is one of the biggest tragedies of my occupational health career of 40 years was to see how employers that were covered by this standard responded. Okay. So this is a chart that's showing the number of inspections that have been done since the late August to mid-February. And so you see 27, mostly in hospitals, but you see across other sectors also. Total of 51 inspections with citations related to the ATD standard and COVID. Now, why no citations before late August? Well, two things. First of all, early on in the pandemic, in early March, most major employers that were covered, hospital systems and others in California, publicly came out and said, everybody knows that this is only droplet spread, and everybody knows there's no need for respirators, and we won't have them anyway, so let's just kind of forget about that. And they went to the governor and early on, and they tried to have the governor use some of his power to essentially eliminate the standard. They were not successful at that. But the governor did put a moratorium on enforcement by state agencies for all sorts of regulation, including Cal OSHA, up until the end of the summer. And so for most of the beginning of this pandemic, and it continues to this day, when I'm working with employers and talking to them about the ATD standard, the primary response that I get is, we follow CDC or WHO, and they don't say it, but essentially they say, we will not follow ATD standard. We don't have to, you can't make us. And it's really tragic, and it's led to lots of illness, lots of exposures, lots of deaths. This is some recent citations that have been issued by OSHA across both hospitals, correctional facilities, and nursing homes. And there's been a huge problem at San Quentin with exposures and some of the other prisons in California outside of healthcare. This is a listing from the fall of a Kaiser Hospital, which historically has been thought to be a very good healthcare employer, but they completely essentially said the standard didn't apply to them. They weren't going to follow it. Once OSHA started investigating and could issue citations, you can just see the list of things that they weren't doing. They were not reporting. They weren't logging the illnesses. They weren't implementing control measures. They weren't providing respirators. They didn't have a plan. And so hopefully with the enforcement, this will get better. Unfortunately, most of these citations are being contested by the employers. And so we haven't seen much result of that. Okay. So if I think about what lessons we can learn from this, based on my experience, I would say, first of all, we need for other states and OSHA, we need an infectious disease standard for workers that's based on an aerosol transmission paradigm that some of the earlier speakers have discussed, not the outdated droplet or airborne paradigm, which sort of confuses everything and misses lots of exposures. The standards must consider novel pathogens so we don't get locked into just what we already know. And I think there's advantages to having separate standards for healthcare and related sites like the ATD standard, and then for general industry, just because there's such different issues that these industries face, and the healthcare workers facing such a high risk. The key to these standards is an employer conducting a site-specific hazard assessment and creating a site-specific exposure control plan that then they have to follow. And employers need to be required to include workers and unions in their involvement and good record keeping. The one issue that was not really ever discussed in the development of the ATD standard was this asymptomatic transmission or pre-symptomatic transmission. And so I think this needs to be thought through and dealt with. And probably we need some sort of a universal precautions approach when there are diseases that have this sort of transmission, as we did with the bloodborne pathogen standard, so we don't have lots of workers where there's just a hope that they're not going to be exposed. And so we need to deal with that. And finally, the last thing I would say is, and I've worked around healthcare for a lot of my career, and I find this really sad and disappointing to have to say it, but until the healthcare sector, infection prevention sector, fully accept responsibility for worker safety and health and aim to excel at preventing occupational exposures to pathogens, I'm not sure how far a standard will get us. It's going to be better than not having it, but I think we really need this sector to step up and decide that they can really do this well, like most other sectors in the U.S. have done. And I'm going to stop there and look forward to having our discussions and answering any questions if we have time.
Thanks so much, Mark. We have a question. Hold on. The seat at the infectious disease table is very important, and COVID is a made for occupational health and safety disease. But some hospitals relied on their OHS professionals and others ignored their expertise. OHS was promoting small droplet spread and control while CDC was dragging their feet. Do you have suggestions for making sure that occupational safety and health is at the infectious disease control table?
I think having these standards and having our professions really stand up and object to the infectious disease dominance of this area. I think certainly the infectious disease sector is incredibly important in controlling these issues, but they don't generally understand occupational health issues and controls in work sites. And I think we need to figure that out. During H1N1, when this standard was first developed, federal OSHA actually had an equal role with CDC because the White House told CDC to listen to Fed OSHA. And we didn't have that during Ebola, and we don't have that now. And I'm not sure how we get past it, but somehow our professions need to be able to work together and not work in competition.
Thanks. Are there any other states that have existing standards on either infectious diseases or aerosol transmitted diseases? Or have any of them implemented new standards during the last year?
Yeah, in the fall, we had the state of Virginia was the first to come up with a sort of infectious disease standard for the pandemic that covers all work sites. And the state of Oregon has done that also. And California also has developed they created an emergency temporary standard for everything that's not covered by the ATD standard. And then, we're expecting the federal OSHA ETS out in the next month or so. But I think it's interesting that, California's ATD standard is one that's been around a decade. There's lots of employer experience and other experience. So I think it becomes a useful tool, a useful experience to look at, although it hasn't gotten a lot of attention outside of California. And, it's been this frustrating part to see healthcare employers who should have been at the forefront of leading the way to deal with COVID in California basically back off and fall back and really not do what they should have done.
Thank you so much, Mark.